Our next speaker for this session is by Dr. Shrikanth Srinivasan. Sir will give his talk on ultrasound guided differential diagnosis on shock. How do we do it? Please, sir.
Very good morning all, and I thank the organizers of GCC for inviting me to deliver this talk.
Sir, let me say something.
You want to say
Sir
something?
is consultant and head critical care medicine. He's in Manipal Hospital, New Delhi. Area of expertise is point of care ultrasound, extracorporeal therapies. Sorry.
So we were talking about resource limited settings, but even a resource limited setting, you won't really get an ultrasound machine, do we? But still, suppose we have a machine. We know that ultrasound is a power tool, and I'll talk about it. In my disclosures, no conflict of interest, no patient was harmed by my scanning, okay? And I did borrow certain slides from a presentation by Dr. Anuj Clark. I'm sure you all know him. So what is the role of point of care ultrasound in shock? We know what shock is all about. It's about acute circulatory failure leading to poor organ perfusion and eventually ending up in poor oxygen supply to the tissues. And as the duration and the intensity of shock increases, the mortality just goes way more higher. The morbidity increases, and the organ damage becomes more severe. Mortality percentage even now, even these days, is very, very high, and that's why the reason is to diagnose shock early and start treatment early. And that's where your point of care ultrasound comes into the picture. First of all, we should know that there is shock. Just having a normal blood pressure doesn't say you don't have shock, right? So blood pressure is one of the indicators, but that's not the only indicator. What ultrasound does is that it gives you simple answers to clinical questions. First of all, is my patient in shock? What is the nature of shock? What is the cause of shock? Is there coexisting multiple causes of shock? What should I do about it? It improves diagnostic accuracy, provides differential diagnosis, and guides specific management, and the information provided is reliable and dependable. But one should remember, it does not take away clinical examination history taking. So that has to be the first thing. Ultrasound comes just as an add-on tool to enhance your decision making and diagnostic capacity. Evidence, a lot of evidence, and especially in undifferentiated shock, there's a very good concordance between the ultrasound findings and the final clinical diagnosis. 100% sensitivity for hypovolemic shock and obstructive shock, 91.7% for cardiogenic, and almost up to 100 for all kinds of shock. So it is a very, very useful device to have on the bedside, and there are multiple protocols. We'll talk about the Rush protocol shortly. And this is the amount of evidence that you have. Now, what is the role? Role is in 3 stages: diagnosis, monitoring, and treatment. When you say diagnosis, first detect shock. What is the type? Is there multiple different mechanisms going on? A combination of cardiogenic, hypovolemic, or cardiogenic plus septic, obstructive plus some other shock. So these are multiple things can coexist in the human body at the same time. So just becoming dogmatic that this is only one and nothing else exists is also wrong. And the treatment has to be fine-tuned. The monitoring will include the progress, the complications, how to guide fluid therapy, when to start vasopressors. All these things can be guided by ultrasound, and the treatment, obviously, procedures, line placement, removing the offending agent in case of sepsis, draining the cause of the sepsis, and so on. Broadly, we classify into hypovolemic, cardiogenic, obstructive, and distributive, and as I said, it may coexist. And this is where ultrasound comes into the picture, because just by history and physical examination, sometimes you may miss coexistence of different types of shocks. So there are specific patterns. What is the entire thought process behind point of care ultrasound is that there are specific patterns which are classical of a specific type of shock. For example, if you have an hypovolemic shock, you will have an empty hyperdynamic heart. Obviously the volume is less, the heart tends to pump, the sympathetic drive is much more higher, the heart tends to pump faster, and the chamber tends to empty out fully. The IVC, if you assess, is totally empty, it's collapsing, and the lungs are dry. On the other hand, septic shock, initially in the stage, may be hyperdynamic, later on may become hypodynamic. The heart contractility may get affected. based on whether you have septic myocarditis or not. And there may be sources, otherwise there may be a vasodilatory state. Cardiogenic shock, you will have obvious changes in the cardiac contractility. You may have wall motion abnormalities. It may be global, as you may think global, and it could be regional. You may have regional wall motion abnormalities as well. And you may have valvular dysfunctions. You may have something which is chronic, and on top of that you have something which is acute. An obstructive shock, obviously you have a set of things which Dr. Dave just spoke about in the previous talk. As I again reiterated the point, multiple coexistent types of shocks are also present, and this is where is a major pitfall when we come to just pure clinical and history taking, because most often than not we add septic shock to everything. You agree? Sepsis. Waste paper basket for everything is sepsis. You don't understand what's going on, sepsis. So that is something which you can probably avoid. So as I said, a protocolized approach is most important, and there are multiple protocols which are being created over the years by these classy, stylish names. The most common or the most popular one is the RUSH. We'll talk a bit more about that. But the integral part of every shock assessment obviously starts with the assessment of the heart. We want to know whether the heart is pumping fine, whether the heart is filling fine, and the heart is ejecting fine. These three are three different things. They're not the same thing. Okay. What is pumping is not necessarily ejecting, and if it is filling good or bad, it depends on how well it's going to pump out. So that's all three are attached to each other. So most of point of care ultrasound is eyeballing. We just have to look at chambers and not do any fancy measurements, and that also gives you a good amount of idea. But it's not just the heart. You have to have an assessment of other parts, including the heart is the pump. We have to have an assessment of the pipes, that is the vessels, the aorta, okay, and we have to have the assessment of the end organs which are likely to be damaged, the lungs being taking the brunt of your fluid therapy. So all these three together, the heart, the lung, the IVC assessment, and abdominal scan, all this come together when you talk about shock assessment. So the pump, the tank, and the pipe, this is the RUSH protocol, rapid assessment for shock in hypotension. It looks like as if we have to do a lot of things, but I'll try to simplify it. When we look at the pump, we are talking about looking at the heart. So there are 4 different views from which you can look at the heart. That's what it's all showing about. When you're looking at the tank, tank is referring to the filling of the heart. How do you fill up the heart? So it obviously talks about the IVC, the inferior vena cava. It talks about the areas where the blood can collect. That's a fast scan. In case of hypovolemic shock, there will be blood collected within the thoracic cavity and the abdominal cavity. And the end point of your damage, that's the lungs. So all these things are part of the tank. And finally the pipes, which will include the examination of the aorta and the deep veins. The questions are simple. With regards to the pump, is there pericardial effusion? How is the global heart function? Is there right ventricular strain? How is the baseline LVOT VTI? That is the basic stroke volume, idea of stroke volume. How much is it? I talk about the IVC. Is the IVC collapsed or full? Morrison's pouch, is there free fluid somewhere here? Is the aorta having an aneurysm or a dissection? And is there a pneumothorax? So these are the basic shorter abbreviated version of the RUSH protocol. And as I said, patterns. There are specific patterns for different types of shock based on the assessment of pump, tank, and pipes. Hypovolemic shock, hyperdynamic heart, pump is hyperdynamic, the tank is small, collapsing, and there is a lot of free fluid collected elsewhere outside the vessels, which is blood possibly. And in the pipes you may have a ruptured aortic aneurysm, or you may have a dissection. Similarly for cardiogenic shock, poor contractility, large non-collapsing IVC, a congested lung which is manifest in the form of excessive amount of B-lines, pleural effusions if you have a biventricular failure, and the pipes are more or less normal here. Distributive and obstructive shock just goes in the same line. What we expect clinically is what we are trying to see on ultrasound. So let's break it down and make it even more simpler for you. Pump. Start with that. First and foremost, look for pericardial effusion. Okay. First of all, is there an effusion? And second, is the effusion causing a tamponade? So this is the video. You can see fluid around the heart. This is the heart chambers, the right ventricle, the interventricular septum, left ventricle, left atrium, the mitral valve, and the left ventricular outflow tract. And this you can see is the fluid around the heart. Why do I say it's around the heart? It's because the descending aorta is below the level of the fluid. So This is fluid around the heart. The question, there is pericardial effusion, fine, it's clear, very obvious. But the next question is it causing tamponade? So we should know what is the cause of tamponade. Pericardial effusion per se really may not trouble you much, but tamponade, yes, is a life-threatening emergency. So there are specific signs of tamponade we'll discuss. Once we have seen for pericardial effusion, we look for left ventricular contractility, global. Hyperdynamic, normal, decreased. If it's decreased, is it global or is it regional? Second, an assessment of the stroke volume. Effectively, the surrogate is velocity time integral, or the VTI. And the third question, look at what is the RV function. Dr. Dave has already mentioned RV function, so I will not talk much about it. Grossly, is the RV looks equal to or bigger than the LV? RV is usually 1/3 of LV. If it's even more than half, there is something problem with the RV. So globally, if you see all 4 chambers, you see RV coming almost close to LV, there is RV dysfunction. Let's start. And then what is the effect of RV dysfunction? Is it acute? Is it chronic? Is there it's causing septal deviation? Is it causing LV compromise? You'll see those things. So pericardial effusion and tamponade, as I said, what are the signs of tamponading? We saw effusion. Signs of tamponading are this. There will be a mid-systolic collapse of the RA. When we talk about systole and diastole, we are talking about ventricular systole and diastole. So during ventricular systole, the RA should be filling up, but the RA is collapsing in mid-systole, and there's a diastolic collapse of the RV. When it should fill up, it is collapsing. So if you have this, and you have the heart dancing like this, if you put it to memory, this is pericardial tamponade. This requires immediate intervention. Tamponading is not based on volume. Tamponading is based on acuity, how fast the fluid collects, right? So that's where the difference totally comes. And obviously, as an end result, you will have an IVC which is also distended. You will have a right ventricular free wall diastolic collapse, and you can see this heart, especially the flopping around like this in the fluid. Coming to the LV function, global LV function, a normal LV looks like this. You can see the RV looks smaller than the LV in both the cycles, the systole as well as diastole. That has to be like that. If it's not like that, there is a problem with the RV, but we are talking about the LV right now. Globally, it will contract very well. The entire cavity will concentrically come closer. There will be no lag or wall motion abnormalities. Hypercontractile, you can see how fast this LV is working. Hypokinesia, hardly working. It's all eyeballing, and I'm not saying what would be the EF here. How much of the LV cavity is actually being emptied out? Less than 15%, number probably less than 15%. You can actually see swirling movement within the LV. This is like stasis of blood within the LV. And you can see wall motion abnormality. You can see the entire apex and the distal IVS not really moving. Unlike this is not moving. This is regional. Okay, so this is regional versus global, hyperdynamic, hypodynamic. Now coming to VTI. VTI is effectively a surrogate of your stroke volume. It's velocity time integral. It's the amount of blood pumped out through the left ventricular outflow tract. So if you multiply the amount of, if you want to calculate it, you multiply the cross-sectional area into the VTI. And how do we take out the VTI? We put a Doppler across the left ventricular outflow tract, and we get this kind of a trace. So if you trace it out, the machine will give you the VTI. A normal VTI will be more than 18. If it's less than 18, then you suggest that there's something wrong in your contraction. As I said, a good contractility doesn't guarantee a good stroke volume. Why? Because there could be a good amount of mitral regurgitation. A lot of your stroke volume is actually going backwards. So the effective thing which is being pumped out is your VTI. And if you just look at the variation in the VTI with respiratory cycle, that will tell you that there is stroke volume variation effectively. So if it's more than 10%, you know that this patient is probably fluid responsive. RV function, okay, normal heart, RV is 1/3 of LV. If you see an RV which looks so big, we know it is wrong. We'll have on top of that tricuspid regurgitation. You put a jet, you see a huge amount of jet coming through that. By seeing the tricuspid regurgitation jet, you can take out the estimate of your pulmonary artery systolic pressures. You can have flattening of septum. As you can see, the septum is usually bored all the time towards the right side, but if it becomes flattened because of increased right-sided pressure or volume overload, then there is a problem. And here you can see what's called the D-shaped septum. The septum getting totally flattened towards the LV. Coming to the tank, we're talking about the IVC. size and variation. Most of us see IVC variability, and very happy, give fluids. That is just one part of the story. We should look at the leakiness, which is leakiness within the lung or into the abdominal cavity, and we look at signs of tank compromise in the form of a pneumothorax. So this is the IVC. We measure the IVC just beyond the attachment of the hepatic vein here at this level, and you can see the variation with respiration. Here you can see there is some amount of variability. Mind you, the IVC variability is actually validated only for mechanically ventilated patient with well-defined pressure swings, just like stroke volume variation, just like your pulse pressure variation, and all those dynamic indices. Even the IVC is also for mechanically ventilated patient. More than 18% distensibility is what is considered as significant. A totally non-responsive IVC or a dilated or a distended IVC could reflect excessive volume, it could reflect right heart failure, both the things. So it's not just look at the IVC and jump into conclusions. And there are lots of conditions, most of which affect the right heart, which will affect your IVC measurements. So there are pitfalls in the IVC measurements. You should always be cautious about that. When I said leakiness of the tank, I meant in the form of increased congestion of the lungs, and the things which you start seeing in the lungs is production of these vertical lines called B lines. And you can see free fluid within the abdomen. Here you can see this some amount of free fluid in the Morrison's pouch is collected here. Tank compromise in the form of a pneumothorax, that's also a cause of shock, an obstructive kind of a shock. Here you can see a lack of lung sliding. That's one of the signs for those people who are actually doing ultrasound. This is a classical sign. Lung point is a classical sign. I will not go into the details of how to go, but this is not the forum for that. Okay. Coming to the third aspect, we talked about the tank, we talked about the pump, the tank, and now coming to the pipes. The pipes, we are talking about the main aorta, and we are talking about the deep veins. So aorta, if we have something like this, if you scan the aorta and you see, what do you see? You see a large thrombotic kind of material. You see two sort of lumens within the aorta, right? This is a dissection with a thrombus. So we have this, and if you have a aneurysm, any dilatation of aorta tapers once from just below the diaphragm, it starts tapering downwards. It has to be less than 2.5 centimeters. If it's more than 3 centimeters, anywhere along the length, probably there is a dilatation of aorta. And it's more than 5 centimeters becomes a high risk for rupture. So when we have a dissection, we have to measure the inner lumen as compared to the outer lumen, and tells you what exactly the dissection is. Coming to the pipes is the DVT scan. DVT scan is done when we are suspecting a pulmonary thromboembolism. So if you have signs of acute right heart failure, signs which are suggesting there is a sudden rise or surge in the right ventricular afterload, so you have to look for some cause which could cause an acute increase in the right ventricular afterload, usually a thrombus. And where do the thrombus come from? From the deep veins of your thighs, or from the neck veins, also from sometimes from the arm. So you can actually compress and do and see that whether the vein is compressible or not. If you see a thrombus there, you don't have to compress, you will actually dislodge it. So that will give you additive and confirmatory evidence that there is a thrombus there. A totally non-compressible, you can see the artery and vein. The vein here is totally non-compressible. So pattern recognition in shock is most important. Cardiogenic shock, poor functioning LV, could be global, could be regional, and the effect of LV dysfunction, which is congestion of lungs, especially left heart failure, there will be congestion of lungs. So you have a combination of these factors and the patient is in shock. Your first thought is cardiogenic shock. Would you like to give fluids in this? No, obviously not. So even if the patient is in hypotension, no fluids. Second, we see this rapid contractile heart, an IVC which appears collapsible with every breath, right? Dry lungs and free fluid within the abdomen. Possibility, hypovolemic shock. Give fluids here. A third combination, dry lungs but signs of right heart dysfunction, dilated right heart, distended IVC, and a DVT scan which is positive. This is obstructive shock. Septic shock, as I said, is a spectrum. Can come in the initial state, could be hyperdynamic. In the later stage could become hypocontractile. The heart can get affected by the sepsis. It will be a vasodilated state. And then obviously you have other signs of sepsis, fever, race counts, procal high, whatever you may think. So you have look at the pump function. We look at the end organs to guide fluid resuscitation, and we try to detect the source, and for procedure guidance. So these are the 4 different ways in which we guide in septic shock. So management, fluid responsiveness by IVC collapsibility, VTI variability, procedure management, how to insert lines under ultrasound guidance, and monitoring. Monitoring, most important, is everything is dynamic. As you give fluids, as you give everything, you can see the changes occurring in the heart. An empty heart starts filling up. You give your dobutamine, a poorly contracting heart will start contracting better. So you can see a real-time insight into what your medication and everything is doing. You give fluid boluses, you see the lungs which were initially dry getting wet. So you stop fluid boluses, give vasopressor instead. So 30 ml per kg does not fit everybody, mind you. So it is not a rule of the thumb that you give 30 ml per kg for every single person. And if you are looking for sepsis, you look for reasons why this patient is in septic shock. So in conclusion, it is a power tool, just another tool. So it has to be along with history and clinical examination. Stepwise approach is very mandatory. That's why there are protocols which are made, and you don't tend to miss out certain steps as compared to other. Do not jump into conclusion by just seeing few images. Try to complete the entire scan. So this is just a part of the puzzle. The whole picture is yet to be seen. So think global, but focus on the regional also. And findings are dynamic and repeated re-evaluation. Importance of saving clips for documentation, because things change over time. You may not be there on the bedside all the time. Some of your colleagues may be there. If you have a clip, it says, "Abhi heart function aisa tha, thodi der baad ab aisa ho gaya." So you have an idea what is there, what is new, what is developed, and you can guide your therapy accordingly. Thank you. I exceeded time. Sorry.
Thank you, Dr. Shrikanth, sir. I think now the questions for all the previous speakers and this speaker.
Yeah, so eloquent, nobody asks questions.
Thank
Excellent.
Thank you, Dr. Shrikanth, sir. Thank you, chairpersons.